for another of our health policy dialogues. These are brought to you by the UTMB Office of the President and the Office of Health Policy and Legislative Affairs. I'm Dr. Ben Raymer. I think I do know most of you. I'm the Senior Vice President for Health Policy and Legislative Affairs. I'm also a professor in departments of Pediatrics, Family Medicines, and Preventive Medicine Community Health. I am pleased to serve as your host today to welcome you to what we think is one of our best of the season health policy lectures. I'm glad we have a full house today, and I'm also glad to see some of our friends from Bald High School. Can you wave your hands up? And some other schools. Thank you for being our guest today. We're here they're here to represent athletic trainers and the coaching staff, the Incuba TOR learning community. TOR, by the way, is TOR, right? I have 3 graduates of Ball High. I think I can remember that one. Our topic today is sports concussion and Texas law. Sports concussion has been featured prominently in the media and most of late with an award-winning movie. It's certainly something that most of you are aware of. Dr. Brent Maisel is here with the transitional learning community. He's a guy who's an expert in this subject. Dr. Bill Molesky in our trauma department. And I think I saw the chair of orthopedics, Dr. Ron Lindsay.
Yes, you did.
Yes, I did. He even brought some of his residents. Time out of the OR, Ron. Thank you. We are really, really happy to share this very special presentation with you, but before we start, I want to get us on the same page, and to do that, Dr. Kenneth Brooks in UTMB's Department of Orthopaedics has done this little clip that you will be seeing. So as we get going, take a look at Dr. Brooks's clip.
I think concussions are a big topic of interest nowadays because of all the issues in the NFL. Players lowered their heads and took direct impact directly on the crown of the helmet, and they both left the game with concussions. When they keep their head up, the spine is curved and can absorb impact. When you lean forward, the spine is aligned straight and it cannot absorb impact, and then the spine is compressed and actually cause injury. Some athletes may experience dizziness, some may experience blurred vision, loss of memory, some may even black out, some may experience headaches. And in fact, if an athlete does take a shot to the head, it's extremely important that the athlete get evaluated by the sideline physician or athletic trainer. Some of the most dangerous concussions are the ones that go unrecognized by both the athlete as well as the coaches and others on the sidelines, as those can build up over the course of the season and lead to brain damage later on. Usually in football, it occurs when either an offensive or defensive player lowers his head into contact, whether it's a runner trying to gain extra yardage by lowering his center of gravity, whether it's a tackler trying to gain leverage by going lower on the approaching runner. One must always remember to keep one's head up and out of the play in football. Keep your eyes on the contact that's coming towards you to help prevent those kinds of head injuries. In soccer, it often occurs from a clash of heads as 2 athletes go for the same ball up in the air and both try to head it at the same time. In addition, because soccer does involve repetitive heading of the ball for many athletes, some athletes may experience concussion-like symptoms due to repetitive heading of the ball, which is why heading is not recommended for younger, pre-adolescent aged athletes.
Okay, so now that we're on the same page, I think, of what we're talking about, it's my privilege to introduce Dr. Shane Miller. Dr. Miller is a pediatric sports medicine physician practicing at UT Southwestern Medical Center and the Texas Scottish Rite Hospital Sports Medicine Center, both of which are in Dallas. I first heard Dr. Miller at the Texas Pediatric Society in their fall meeting. He is an extraordinary individual in his experience and his training. He completed medical school and residency training in pediatrics at Baylor College of Medicine and Texas Children's in Houston. He's familiar with Galveston and the Houston area. He was selected for a fellowship in sports medicine at the University of Colorado in Denver and Colorado Children's Hospital. He joined UT Southwestern as an assistant professor in both the Department of Orthopaedics and Pediatrics in 2009. We're really honored to have Shane Miller here today to share his expertise with us and give you a chance to ask some questions. For first and second year med students, this will be on your next exam. If you believe that, no.
Thank you guys for coming and giving me time to address you on this topic. This is something that has become a big part of my practice and interests, and from a young athlete as my child growing up, having had concussions myself, it's a very different the way that we recognize and manage these now. And I think that a lot of it is because there's still so many unanswered questions. So I will try to give you sort of a review of the current state of awareness and management of concussions and health policy, but there's a lot of unanswered questions, so we'll think about future directions and which way we may go. Unfortunately for my family, I don't have any financial disclosures. We're gonna define concussion. We're gonna review epidemiology of concussions, and again, mostly this talk is focused on sports-related concussions. Certainly, there are a lot of concussions that occur in motor vehicle collisions, falls, other ways, but we're focusing on sport-related concussion today, and outline our current Texas legislation regarding sports-related concussion, as well as discuss future health policy directions. So our first patient today is a 10-year-old male who presents for evaluation following an injury that occurred 2 hours ago while he was at football practice. So here's a clip of what happened to this young man. So 4 or 5 dads standing around thinking that that's a good idea. Let's line our children up about 10 yards apart and tell them to run full speed at each other and hit their heads. Anybody in here remember doing that growing up as a kid at practice? I did, right? Still being done. So, maybe those things are preventable. Maybe we can make some changes, because otherwise I think we're going to lose sports the way we know it, and sports are very vital for lots of things. There's so many benefits of sports participation in youth growing up, other than just winning, that I think we lose sight of oftentimes. So concussion, what is a concussion? A concussion is a brain injury, is defined as a complex pathophysiological process affecting the brain induced by biomechanical forces. Does anybody else know what that means now? Not very helpful definition, I don't think. So we kind of try to break it down a little bit. A concussion is a brain injury. And I think that's important for families and patients and parents to know, that that's really the gist of it. This is a brain injury I was talking about. It's not an ankle, it's not a knee, it's the brain. And so that's why we're interested in this. The brain's sort of important, and we think that maybe down the road we're going to need it, and most of us are not going to become professional athletes. It's caused by a direct blow or impulsive force transmitted to the head, and it causes impairment of neurologic function that typically will resolve spontaneously over a period of time, usually days to weeks. In the past, it's thought that this is mostly a functional disturbance, not a structural injury, so you're not going to see this on a CAT scan or an MRI. Okay, some of the newer imaging and research-based things, we may be able to start to pick up a little bit of this, some of the axonal injuries, but it's really more on the microscopic level. And most of them don't involve loss of consciousness. So there are millions of concussions occurring every year, and a lot of those are occurring during sports play in our youth athletes. There's a significant increase since we've been tracking these, and I think a lot of that is increased participation, increased awareness, and now athletes are bigger, stronger, faster than they used to be. The style of the games have changed. If you watch the way that the NFL players are hitting and tackling each other now, they sort of just launch their body and try to take out the other player, as opposed to 30 years ago when it was sort of wrap up and tackle and keep your head out of things. So we're trying to shift back. But it's an effective way of tackling, which is why it works, and it usually takes their opponent out of the game. High school sports, there's a lot more participation, again, so part of that is why there's been more injuries. But when we look at sports, football is typically thought of as number one, and it usually is, but a very close second is girls soccer. And my practice mimics that. I see lots of football concussions. I see just as many concussions in girls soccer. If you look at girls soccer versus boys soccer, it's almost twice as many in the girls. You look at girls basketball versus boys basketball, 3 times as many in the girls. So there are lots of thoughts and theories on why that's happening. Some of that is that I think that girls are going to be more honest and they're going to report a little bit more often than the boys, but there's also a lot of physiologic reasons. And just having covered both girls and boys sports at multiple levels, the girls oftentimes are more aggressive than the boys. You watch girls soccer at the collegiate level or at the youth level, the girls will get after it and take each other out a little bit more, and it's sort of encouraged, and that's sort of the culture. An athlete exposure, for a lot of these studies that we're going to be talking about, sort of when we're looking at incidents, an athlete exposure is defined as one athlete participating in one game or practice in which he or she is exposed to the possibility of athletic injury. So if you have 30 kids on a team at one practice, that's 30 athletic exposures right there. So that's how we sort of try to figure out how often these things occur. One thing that I think is important to know is that concussions occur much more frequently in gameplay than they do in the practice setting. Practices are typically more well controlled, a little bit safer, so it's significant increased risk of concussions during competitive gameplay than in practices. The biomechanics of the injury itself is, it's not just the typical, what we could think of as coup and contra coup type injuries where the brain is hitting the skull and hitting the back of the skull, but there's also a lot of rotational and shear type forces. So oftentimes we'll see an athlete that may get hit in their shoulders and spun around, and their head just spins very quickly, and they'll come off sort of dazed and concussed. And it's not that there was a direct blow to the head, or sometimes they'll take a very significant G-force blow to the head, and it's not so much the linear vector, but oftentimes it's the rotation that occurs that the brain is having a hard time withstanding, and there's some shearing in through there. So here's a little demo sort of showing what the brain does. I often describe this as like an egg and an eggshell and a yolk. So if the skull is the shell, the brain is the yolk inside. So if you shake an egg, that yolk is going to move in through there, but the skull may be okay. So that's why our current concept of helmets and other things are not really functioning at reducing concussions. They're great at reducing the risk of skull fractures and brain bleeds. They'll protect that skull, but it's sort of like a car from the 1950s that was all steel. You'd get in a wreck, and that car would just have a little tiny ding in the fender, but then the passenger would die. So now you look at our cars, you run into somebody backing out in the parking lot at the grocery store, and your car is totaled because it collapses around you, but yet the passenger compartment is fine. So I think we may see some changes in some of the equipment to sort of think about that same concept. The pathophysiology of this, we're still trying to learn. It's hard to study the pathophysiology in the human brain, so a lot of our basis comes on animal models. And essentially there's this whole concept of what we call a neurometabolic cascade, where there's disruption of the cell wall of the neurons, and so then you have potassium efflux. The sodium-potassium pumps start kicking in, they burn up ATP, and so you have this whole neurometabolic energy crisis going on in the brain. The brain is not able to function. And so when the athlete or the patient says they feel foggy, they feel slow, they can't do things that are typically easy for them, their brain is literally not able to send the signals in the typical pattern that it used to be able to do. And this can go on for quite some time. This is sort of just a graphic showing some of these changes in a rat model. And if you look across the bottom, this takes hours and days to weeks to evolve. Sometimes the injury doesn't, the injury will occur at time zero, but the athlete may feel okay. They have adrenaline going on, they're in a game, and because some of these neurometabolic processes having occurred, so 2 hours after the game, they're sitting at Subway, and that's when they start to feel a headache and they start to feel really bad. It's not that they were hiding the injury always, sometimes they were, but it's that some of this injury is evolving and the processes within the brain have actually changed. One concept that's important to me as a pediatrician is that not everybody recovers at the same rate, and we think younger athletes recover longer than adults. The younger brain is still developing. It's still getting what we call myelin, which is the insulation, sort of the and the protection for the brain. Younger kids have a large skull but a small body, so they're sort of like bobbleheads. So it's easier for them to have these injuries. And so an adult, oftentimes, it's unusual for a professional athlete to miss a game the following week. Sometimes they're out 2 weeks, but usually they're back the next week. That's less common in our pediatric and adolescent patients. They're often 3 to 4 weeks. So this is showing in sort of high schoolers, if you look at week 1, day 7, only about 40% of them will have recovered within the first week. 60% at week 2, 80% at week 3, 90% by week 4. So when we say 80 to 90% will have recovered within a month, that changes things because I think most families and patients expect that they should be back to normal within a couple of days, and if their child is still having a headache 4 days out, wow, something's really wrong. Why are they not back to normal? Well, these younger brains, they take a little longer to recover. So as Dr. Brooks mentioned in the opening video, symptoms can really vary. We tend to break them down into 4 categories. So cognitive or thinking type symptoms, physical or somatic symptoms, emotional or mood symptoms, and sleep issues. Oftentimes athletes will have symptoms in multiple categories and they'll kind of all overlap. So headache is by far the most common symptom that most people will complain of, but not every headache is a concussion and not every concussion has a headache. So we see lots of other things. I find in the younger patients, sort of under the age of about 12 or 13, they have a hard time telling us anything other than my head hurts and my tummy hurts. Maybe I'm sleepy, but they can't tell us, well, I'm having a little bit of difficulty remembering today. So as a pediatrician, we have to sort of be aware when they're coming off and having injuries that maybe they don't just have a stomach bug and maybe there's something else going on. But we have to treat all of these differently. But if you're not sleeping well, you're not going to be able to concentrate at school. If you have a headache, you're not going to be able to sleep well, and then you're not going to be able to concentrate at school. So we kind of have to figure out what's the cause and try to treat these things so that they can recover and do well. And oftentimes we're treating the symptoms as much as we are the injury. When we're evaluating a concussion, it always starts just like anything with a good, thorough history. We want to know what happened. Was there loss of consciousness? And how did they feel? Did they report the injury? Did they continue playing after the injury? Have they had previous injuries? And if so, how long did it take them to recover from those previous injuries? Anybody in the family, or do they have a history of migraines or other headaches, ADHD, depression, other mental health or psychiatric issues? Oftentimes will complicate their recovery and prolong the recovery. We very commonly will see some of these things that had never been diagnosed that will come out following the concussion. So a child who maybe had some anxiety or depression was doing fine until they got to this injury, and now all of a sudden they kind of sink, so to speak, and then we're able to diagnose these previously existing subclinical issues. The complete physical examination, Dr. Brooks again mentioned the neck. I always examine the neck. I'm looking for signs of skull fracture. I'm doing a full physical exam, making sure there's no other distracting injuries. Oftentimes they can have another injury if there's a traumatic brain injury that you're missing. Complete neurologic exam, cranial nerves, neurologic exam, cerebellum, strength, and then oftentimes I'll do what's called the SCAT-3, which is assessing the mental status, because most of the time the history the physical and neurologic exam is fairly normal. There's a couple aspects that I'm going to talk about that we focus on, but I want to look at the function of the brain, and so trying to assess their mental status. The SCAT-3 is sort of similar to a mini mental status exam for those of you who remember doing that, but it has a symptom scale, which I find very valuable, because if I ask an athlete, how are you feeling? I feel fine, doc. Especially our teenagers. That's about all you're going to get. And so you have to probe, okay, well, are you having any symptoms? Yeah, I've got a little bit of a headache. Great. It's sort of like asking, how was your day at school today? Fine. So it's kind of all you're going to get. So the symptom scale is very helpful, and it has 22 symptoms from 0 to 6, 0, none at all, and 6 is really severe symptoms. And they go through and they rate themselves on paper. And then you sort of get a real idea of how they're feeling. And so I won't clear an athlete back without making them write down their symptoms on paper. Tell me how you're feeling today, because they're a little bit more forthcoming on paper than they are when you ask them, and they can show things a little bit better. It has a cognitive assessment and a balance examination. There's an adult and child version that came out, the child version ages 5 to 12 and the adult version ages 13 and up, and it kind of walks you through it. So if you ever get in a situation where you need to evaluate a patient, you can look this up online, just download the PDF, and it walks you through the instructions, tells you how to do it, tells you how to score it, and you don't have to memorize it or really know how to do it beforehand. Asks about signs of a concussion, loss of consciousness, loss of memory, amnesia, retrograde amnesia, anterograde amnesia. Maddox score, these are ones we only do when we're on the field, on the sideline or on the soccer pitch. And so we'll ask questions that an athlete should know. If you ask a football player who the president is, if they don't give you the right answer, it may not be because they're concussed, okay? But if you ask them, what stadium are we playing at today? They should know that. What half is it? Who did we play last week? Did we win? What's the score right now? Ask them questions that they should know. We used to do, as part of the SCAT now, they have you do count the months backwards, say the months backwards, December, November, October, so on. And we used to have them do serial sevens where they would count backwards from 100, but we found that a lot of our athletes can't do that at baseline, so it was not as helpful. So we modify our exam for them. balance testing and visual testing are probably two things that I focus on personally when I'm examining, but also when I'm teaching my residents in clinic with me, is to look for. Because when I came out, I was seeing a lot of these abnormal vision and abnormal balance things, but it hadn't really been out much in the literature. Now they're starting to catch up a little bit, but you see it. And so when an athlete is telling you that they're fine, they want to go back, but they're having problems balancing in one foot, then you say, you're not ready to go. If they're telling you they're fine and they have a lot of nystagmus with their exam, they're not ready to go. They may think that they are, or they're trying to convince you that they are. So one of the things that I always do is balance testing. So this is called the BEST, the Balance Error Scoring System. And you look at it they do 3 different tests, and we're kind of assessing how much they're balanced. So this is a young man. You can see on the left is a couple days after his injury. See how much he's swaying. He's having to catch himself on the exam table there. And then on the right, 2 weeks later, he's perfectly stable. There's no sway. He's doing very well. And then in a second, he'll move on to a single leg stance. And you'll see really a lot of truncal deviation, and he's having to put his foot down again. He really can't balance very well. And then 2 weeks later, he looks fine. So again, it will improve often with their symptoms as well as their neurocognitive function as they get better. Eye movements is another thing we look at. So this is his initial visit. We're just trying to do smooth pursuits, just a very basic exam with him. And he's having a hard time focusing on my finger. It's causing a lot of symptoms with him. He's blinking a lot, and his eyes keep coming back to the midline, even though my finger is not. And then a couple weeks later now, he's recovered. Hair's a little bit longer. But now his eyes, he's able to track. So if you send that young man on the left to school and tell him to try to go read or try to go take notes in class, he's not going to be able to. Not because he doesn't want to be in school, but because it's going to make his head hurt so badly, he's not going to be able to keep up. And so that's where we pay attention on our physical exam. We apply that to our management and say, you may go to school, but you need to listen. You can only listen and absorb, because you can still learn, but you're not able to learn visually, so we need to have pre-printed notes for you. So we take our exam and apply it to our management. This is sort of showing the rest of my visual exam that we go through, and take them through a little bit of a detailed exam. Oftentimes when patients are having lingering symptoms, they're being referred to us for a second or third opinion. They're not getting better. We find that they have ongoing vestibular or visual dysfunction. We treat that, and then they tend to get a lot better. So there are a lot of times they're not faking. Neurocognitive testing, you guys may have heard of a test called the IMPACT test. IMPACT is one brand of computerized neurocognitive testing. Again, we're trying to assess the function of the brain. We're looking at memory, we're looking at reaction time, visual motor speed. It's very nice if you have a baseline on the athlete prior to their injury, so you can compare them to themselves. But if not, we can still get a pretty good guess based on their academic history, based on how they do on standardized testing. But this is one tool that we use. This is not a pass-fail thing. And I usually say rarely does it change my impression or management of the patient, but very commonly it convinces the parents that their child is still injured and we know what we're talking about and that they shouldn't be on the soccer field. So that's some subjective data that go along with that. So concussions now are a clinical diagnosis based on our history, our signs and symptoms, our exam findings, our neurocognitive testing, our balance, and our visual testing. We are no longer grading concussions, so please don't call them grade 1, grade 2, grade 3, mild, moderate, severe. We used to do that, but we've moved away from that. So these are mild brain injuries in the whole scheme of things. This is not somebody who ends up intubated in the ICU following a bad motor vehicle collision. We understand that, but when we call it mild, that tends to downplay the fact that this is still a brain injury. So it is a concussion, and it's hard for us to predict how long it's going to take them to recover or how bad the injury was until they've fully recovered from it. So if it takes somebody 6 months to recover, that's a bad concussion. Even if it seemed very mild at the beginning. So that's why we don't grade them and make return to play decisions based on that. Here's another example of an injury. See him sort of go up. So he wasn't even hit head to head. He just sort of gets flipped up, comes down, and lands. Sometimes it's really obvious like this. So sometimes it's really obvious, sometimes it's not, and that makes it difficult for us when we're on the sidelines. It makes it difficult for coaches and athletic trainers, parents to try to see what's going on if the kids are not telling us. So the way we manage concussions is typically we sit around and wait for the brain to recover and heal, and that's frustrating. If we have other injuries, there are things we do. We intervene, we start medications, we do treatments, we do surgery. But as a brain injury, we don't have a great treatment right now. So we manage the injury, manage their symptoms until the child or the athlete recovers most of the time. So we tell them to rest. We tell them not to play their sport. We tell them to back off of school. Get lots of sleep. Don't drive a car. At least I don't want to be on the road with them if they're not able to balance and move their eyes around. Cognitive rest from school. Children who tried to go back fully and didn't take any break took longer to recover than kids who either stayed home or did a little bit. So I usually ask them, say, they shouldn't go back if they're still having symptoms or evidence of a concussion. If their exam is abnormal, they're still having headaches, they're not ready to go back to play. When they are ready to go back to play, they go through a gradual progression of increasing levels of physical exertion, which we'll show you in a second. And that takes about a day for each stage. And they obviously need to not have symptoms come back as they're going back into things. So I usually say if you have any exercise symptoms, if you have symptoms that come back during or after exercise, that tells us you're not ready. But if I made you go jog and your headache comes back, it's okay, no harm done, you got a headache. But if I put you back on the football field and you're not recovered, now you're hitting, potentially harm done. So that's why we're testing them out sort of in a safer environment before we put them back in their competitive environment. So here's an example of a sort of progressive return to play. The first stage is just rest. Let them rest completely. As they feel better, we start to get some light aerobic exercise, pump some blood to the brain, get their heart rate up, get their blood pressure up, see how they tolerate that. Cerebral blood flow is impaired after an injury, so oftentimes exercise, getting their blood pressure up, will bring their symptoms back until that is equilibrated, and so they're not ready to go. Then we move on to sport-specific exercise, running sprints, that sort of thing, to add some head movement in. Then we move into non-contact drills, back into full contact practice, and back to return to play. They can't skip any stages here. So if I see a child on Tuesday and they want to play in a game on Wednesday, it's not going to happen. It's going to take us at least 5 or 6 days to get them back. And we'll talk about the state law, how that may affect things as well. Why are we worried about them going back? There's a concept known as second impact syndrome. It's a little bit debatable sort of in the neurology and sports medicine world right now, but the theory is that if you take a second blow to the head while still recovering from the first injury, remember we talked about that energy crisis and that neurometabolic cascade, that impaired cerebral blood flow. The brain is not able to respond to an injury the way it normally would, so there's cerebral edema, which can lead to significant morbidity, death sometimes. Typically only happens in the adolescent, sort of under 25, so 15 to 25 age population, no documented cases in adults. Again, going back to that adolescent brain, and that youth brain is maybe not the same, and the brain continues to myelinate and to mature up until about the early 20s, maybe 25, depending on sort of what you look at. So we worry about that, but it's a rare thing. But certainly, if you have an athlete that goes back and dies, that's not an outcome that any of us want to ever experience. Prolonged recovery. If they continue to play after an injury or they go back too soon, they're going to take longer to ultimately get better. I very commonly see athletes that have maybe lied to their athletic trainers, or they've downplayed their symptoms, they've gone back prematurely, and they take a little mild blow to their head, they get another concussion, and now they're taking forever to recover. Risk of long-term neurocognitive impairment is certainly something that we'll look into. I always say, when in doubt, sit them out. I want to touch on this because I think that this is what you're seeing a lot in the media. Chronic traumatic encephalopathy is a concept right now that is extremely controversial in our world and is debated a lot among very smart and bright people in neurosurgery and neurology and pathology and sports medicine because it's so new that I think that we all agree we're seeing something, but we don't know what it means, we don't know how to predict. It sort of describes, in a clinical situation, these types of symptoms: poor function, paranoid ideation, rampant mood fluctuations, insomnia, depression, increased religiosity. So that's not a specific clinical diagnosis right there. Dave Duerson of the Chicago Bears, Junior Seau of the San Diego Chargers were both found to have CTE. CTE is diagnosed right now by direct tissue exam, autopsy, meaning you have to be dead. We're having a hard time diagnosing this in living people. The brain looks grossly normal, but you're seeing that there's a buildup of amyloid precursor protein and tau deposition. And so we're starting to look, it's not exactly like Alzheimer's, but it's starting to look sort of like a younger brain who has advanced dementia. Owen Thomas was a 21-year-old football player at Penn who had never had a diagnosis of a concussion previously. He hit really hard. He committed suicide in 2010. This is what his brain looked like when they examined it in Boston. So you can see in his brain here these little areas of abnormality that you should not be seeing in a 21-year-old's brain. And so what does that mean? Again, we don't know yet. We're still trying to figure it out, but that's abnormal. And so are some people susceptible to this and others not? Sort of like Alzheimer's, still a lot of unanswered questions, things we're trying to figure out. And this is sort of showing you a normal 65-year-old on the far left, an NFL player who was diagnosed with CTE at age, when he passed away at age 45. And then look how that looks similar to a boxer with dementia who's 73 years old. Not exactly the same, but I think that certainly some concerning findings in through there. So moving on to a little bit of the purpose of why I was invited here is to talk a little bit about health policy and some of the laws. So I'm proud to say that now, in 2016, all 50 states have legislation regarding youth sports concussions to some degree. They all vary a little bit, but oftentimes they address education, they address the ability to return to play, they address physician clearance in many cases. 2009, I was up in Seattle at a conference. So up in Washington, Dr. Stan Herring, and they signed the first concussion law. It's now known as the Lystet Law. A young boy named Zachary Lystet suffered a devastating traumatic brain injury. He's still alive, but is severely impaired because of his injury. And the thought is that there was a lack of education and awareness that could have prevented him from being in this injury. His parents are really amazing people, and they teamed up with Dr. Herring, who's one of the Seahawks and Washington Huskies team doctors, as a physiatrist up there, and some of the legislatures and the governor, and they passed the first law and really set an example that sort of spread across the rest of the United States. 2009, Oregon also passed their law. 2010, you see a few more now have passed. 2011, Texas came on board. So that was a big deal because Texas was a little bit ahead. The South and the Southeast tend to sort of lag behind in lots of things from a health policy perspective. Unfortunately, whether it's obesity or healthcare insurance, we tend to lag behind. So I was proud of our state, especially being so crazy with football and how important things are here, to say this is an important enough issue that we think we need to jump on board early. You know, Florida and California are still not on board yet. So that's a big deal for us. 2012. Now you're starting to fill in the country a little bit more. 2013, see, I told you the Southeast is still behind us, right? And then now the 2014. They're still really good in the Southeast Conference, though. I'm a Longhorn, so I don't know. They're doing something right over there. So in 2011, we passed what was known as House Bill 2038, also commonly called Natasha's Law. And this applies to UIL sports, so middle schoolers and high schoolers that are governed by the UIL. Does not apply to private schools. They were originally going to be included in the law, but they threatened to sue the state. So the state said, that's okay. You don't need to be included. It doesn't apply to youth sports that are club sports. It doesn't apply to people that are not involved in UIL activities. So It's a little bit of a video here to show you, just so you can kind of understand who Natasha was. They had the Lystet Law in Washington. Now this is for Natasha Helmick here, Natasha's Law in Texas.
My name's Natasha Helmick, and I'm 22 years old.
It's about a 5-minute
I've been
video,
playing
so.
soccer since I was 4 years old, and my soccer career ended my freshman year of college due to a concussion. I got my first concussion, I was around 12 years old. I didn't know it was a concussion at the time. I was in a soccer game and I went up for a header. A girl next to me went up for the same header and her head hit me in my temple. I went down. They stopped the play. I got up. They asked if I was okay. I said I was fine, even though I wasn't. My head just felt like it was wanting to explode. Went off to the sidelines, sat there, looked my coach in the eye, sat there and looked at me and was like, "Tasha, are you okay?" I said, I'm fine, put me back in. I wasn't playing normal because for the next 60 minutes, the remaining of the game, I couldn't see out of my left eye, so I was missing balls coming in from this direction, and my parents were walking over to me before they could even make it to me. I just started throwing up, vomiting, signs of a concussion, and that was my first concussion. Did not know it was going to be trail leading on to many more. The next one probably would be going up for a header again, and girl hitting me in the back of my head with her head. I just remember hearing the loudest ringing noise. Everything just was moving in slow motion. I continued just to play through it, and the ground was just going like this, back and forth, and I couldn't tell what was the ground and what wasn't the ground. 2 days later, I went to school, and that was really hard. Couldn't even really make it through a full day of school. I would just start feeling dizzy, like I'm gonna pass out. I would start seeing 2 teachers. I would start seeing 3 pencils. It was just really frightening, I guess. I just really wish I wouldn't have tried to play through and be the tough person. And I just didn't want to let my team down. I didn't want to let my coaches down. But in the end, I was letting myself down. So, because in the end, they don't have to live with what I feel today. That was my choice to stay in the game, to try to tough it out. They don't deal with the day-to-day things I had to go through, whether it be I'm really dizzy one day or I have really bad headaches and I want to get out of bed. They don't feel that. And all those games I went back in or toughened it out and kept playing, I don't even remember any of them anyways. So I kind of look back and be like, man, what was the point of all that? I mean, I understand the drive of an athlete and everything. I just wish I would have been smarter and just not hit from my parents, hit from my coaches. And, I wish I would have thought more long term, not just in the moment now. I wish through all my concussions I just would have been more honest. I mean, I do miss soccer. But now when I think of soccer, I think of like pain. I miss feeling normal. Yes, that's what I really miss. Don't be afraid if you can't go to school or if you have to give up that sport completely. It's gonna be scary and it's gonna really be tough, but you can get through it. Just don't compare yourself to other people because they haven't gone through what you have, but that you can do it and just keep positive, and life is definitely worth living. Just make the best of it. That's what I would say.
So
One of the themes that you saw there was that she kept playing. She was lying to the coaches and was trying to tough it out. Didn't want to let down her teammates. Just kept pushing through. And so part of everything that we're talking about is the law. That she really believes strongly that had there been more education about sort of what she's experiencing now, that perhaps she would have made different decisions. And so she was one of those who went before the legislature and sort of helped testify to get the law passed. So the law in Texas, it caused each school district to have to create what's called a COT, or a concussion oversight team. So every school district, whether large or small, whether suburban, rural, urban, has to create a COT. Every COT must include at least one physician. It may include athletic trainers, neuropsychologists, other nurse practitioners, other people, but it has to include a physician. And the job of that COT is to outline a concussion management and return to play policy for each school district. So we're at least trying to standardize within a school district how concussions are managed. They didn't come out and just say everybody in Texas has to manage their concussions exactly the same way, but you have to come up in your school district how you're going to manage them. At the beginning of the year, every student and their parent or guardian must review some concussion education information of some sort and sign a form acknowledging that they've learned about concussions prior to participation each year. Again, trying to educate parents and athletes about the concussions and get them on board. It requires a training course every 2 years for coaches and any member of the concussion oversight team. They have to go through 2 hours of continuing education every 2 years. But ironically, physicians who have to be on the COT are not required to do the continuing education. So, hopefully the physicians that are involved in these and are giving the school district guidance are at least doing it on their own. Immediate removal from play for any athlete believed to have a concussion. So we pull them out of the game. The original wording says any athlete suspected to have a concussion, but they were worried that perhaps an opposing coach might say, I think their quarterback has a concussion. I suspect he has a concussion. Now he has to be pulled out. He's evaluated and he's out. So they changed it to believe, meaning after evaluation, if we think that they have a concussion, that they have to sit out. So when we say when in doubt, sit them out, but keep them out. They cannot go back to play the same day. So a student shall be removed from an interscholastic practice or competition if anybody thinks that they might have sustained a concussion during the practice or competition. A coach, a doctor, any licensed healthcare professional, or the student's parent, guardian, or somebody else who has legal decision making for them can pull them out. So it doesn't say official on there. So oftentimes the officials can sort of recommend that we evaluate them, and that happens during the football games. It requires a progressive return to play, which we talked about, once they're completely symptom-free following guidelines. It requires a signed clearance by the physician. So this is a big change. Now a MD or a DO has to sign off on an athlete to be able to return, again at the UIL sports, before they go back. So the parent can't make that decision, the coach can't make that decision, the athletic trainer can't make that decision. The athlete themselves can't make that decision. So if we've pulled them out and started to say, hey, we think that they might have a concussion, they have to get written physician clearance before they go back. This past legislative session, the chiropractors lobbied and tried to pass a bill allowing chiropractors to also sign off, but that did not pass. So this shifts liability to the physicians and requires that physicians are up to date, because I work with lots and lots of athletic trainers who know a lot more about concussions and managing them than many of my physician colleagues do, because the last thing that they did was in medical school however many years ago, and now they're maybe a pathologist or a obstetrician. So I think that it requires that physicians are continuing to do our job of paying attention, but it does sort of shift the liability a little bit. One of the reasons that it's important is because we're dealing with athletes like Natasha who hide this from us. They don't report their symptoms. And so this was a study that was done, a survey, and it was presented in 2004. It shows that 47% of players who sustained concussions kept playing without reporting their injuries. So half. And why didn't they report their injuries? 2/3 said they didn't think a concussion was serious enough to report. Well, we're trying to educate. Let's try to change that. 40% said they didn't want to leave the game. 40% didn't realize they had a concussion. That's fair. Didn't want to let their teammates down. That's a big one too. So I've been using this slide in my different talks for a long time, and I've sort of said, I bet this has not changed very much. I deal with athletes, and I bet this hasn't changed very much. So I was glad to see this study come out last month, in January 2016, Clinical Journal of Sports Medicine. So they did a study again in 2013, a survey, and compared it to that survey back then, same state, Wisconsin. Oops. And so the rates haven't really changed much. It went up a little bit, 16.6% versus 15% back in 2002. But athletes now are reporting 71% of the time they're reporting their injury versus 47% of the time. So that's changed. They are reporting their injury more. The reasons why they're not is still pretty bad, but 60% of the athletes knew about the law in Wisconsin. That means 40% of them, even though it's a law that we have to educate them and their parents have to sign off on these sorts of things, half of the athletes said, we didn't even know we had a law about concussions. So we think we're doing a good job, but we're not there. 55% of them did say that the law would make them more likely to report a concussion, and less than 10% of them, which I thought was important, said that they would be less likely to report it. That's one of our fears, is that we put in a law, we put in rules that the athletes are going to hide the symptoms because they know we're going to pull them out of the game, but only 8 or 9% of the athletes said that we're probably not going to report my concussion because I know about this law. So I think that was a good thing that came out of this, but still a significant percent, 30% not reporting their symptoms. And I was looking back at some of my data that hasn't been published yet, but 40% of all of my athletes in the past year continued playing after their concussion and went back into play after their concussion. 40%. So 2016, we're not doing the job we think we are if we think it's that important for them to come out and stay out, if that's still going on. And it was significantly higher in specific sports. Football, it was more than 50%, about 60% of them kept playing after their injury. So we need to continue educating. This was one from, again, 2014, the effect of coach education on reporting of concussions. So does a better educated coach, do we get them to report the concussions? And so they looked at girls soccer and football and actually found that the concussion rate was the same, which is similar to what I said before. Girls soccer was a close second. And it was about 10 or 11% over the course of a season. So 1 out of 10 athletes is going to sustain a concussion on the team out of the season. But this says 70% of the concussed athletes reported playing with symptoms. So they either didn't know they had a concussion or they kept going. So again, it's a big problem. 70% of them kept playing after they had symptoms that at least were suspicious or met with a concussion when they should have been evaluated. 40% of them said their coach had no idea that they had a concussion. And so I've been a team physician for a long time. I stand on lots of sidelines from high school football to professional hockey, and I will tell you that as much as we are trying to watch every single play and see every injury, there are lots of bodies, there are lots of plays, things happen very quickly, and there are times that we don't know that an injury has occurred. And sometimes, if somebody injures their ankle, we can see them. They're hobbling around the next play. They're slowed, right? But when it's the brain, so we have to depend on the athletes, to be honest. We have to depend on their teammates to help tell us if so-and-so shows up in the huddle and doesn't know what's going on. And we can't, always blame the coaches on not recognizing these, because they're looking down trying to figure out what the next play is. And so it's not as easy, I think, as we think it may be sometimes. And that's why the NFL and others have put in sort of independent consultants, athletic trainers and neurologists in the sidelines and up in the stands who are watching, who are not even supposed to be on the sidelines, so they can watch for a concussed athlete. So it's a big problem. This is looking at, they asked coaches basically how much information they had gotten and how knowledgeable they were. And they found that the education was pretty good. The coaches were pretty knowledgeable at answering questions we wanted them to know about concussions. Athletes, only 35% of them had been exposed to more than one sort of, if you hand an athlete a handout that they say they have to go home and sign, their parents are going to sign, the likelihood that the athlete's going to read it and or the parents are going to read it, or actually the parent may not even sign it, right? It's probably forged half of the time, because Mom, I got to sign this form just to play, and Mom's going through just signing things. And so, we got to probably hit them with more than one modality, just like in medical school. We don't just hand you a syllabus and say, go home, right? We're trying to educate you and find, how do you learn? Let's try to get you multiple different ways. And so that's sort of where this study said the same thing, but only 16% of parents heard about concussions from more than one modality. And so it's a big problem. Let's see. So this is another study that came out in 2015. So they were looking at our ability to educate. And they said that simply presenting information may help to increase knowledge about concussions, like in the coaches, but it does not translate to changes in behavior. Okay? So we think we're doing the right things, and we're trying, and we're enacting policies, we're enacting laws, but it's not translating to behavior changes. So they say psychosocial theory-driven methods used to understand what athletes are thinking and improve buy-in from athletes and coaches and parents from intended audiences have shown promise in changing behavior. So that's where we need to go with this. We need to figure out what works. Why are we not making this gap? The medical community's over here and sort of the athletic community's over here. How are we going to cross that bridge and get on the same page, work together to sort of solve this problem? Moving forward into future directions. Research, obviously there's got to be more research. I'm part of what's called Context. It's the North Texas Sports Concussion Network Prospective Registry Study. We just started this about 2 months ago, and it's a multi-center study where basically right now it's a database so we can answer lots of questions, but we don't have anything right now that's evaluating the effectiveness of our state law in Texas, that's evaluating the effectiveness of our treatments, right? I'm telling you that I'm putting kids back in school and getting them back sooner. Is that more effective than staying home for 2 weeks? I think it is, but can I show that it is? So we're trying to look at these things to answer questions. So this is multiple institutions working together, and this is part of it. It's actually a grant we got from the state of Texas to help us do this. With the goal is to start off small, get the kinks worked out, then expand it statewide, involve athletic trainers, involve our partners down here as well as across the state, west and elsewhere. So hopefully more to come with that. In terms of prevention, obviously as a pediatrician, I think prevention is great. That's why we do well-child checkups and vaccines, is if we can prevent a problem, that's much better than dealing with it once we have it, especially when it comes to a brain injury. So I think rule changes, if there's a clear-cut cause and the science is there to back it. I think arbitrarily just coming and saying, we're going to change this rule because it might work, we can't change the sports too much until we really sort of analyze some of these things. Violent behavior, aggressive behavior, to me is a very, very big problem that is a preventable risk factor that I think changes. I commonly will see the little, small, skinny hockey player that comes in because he'd scored four goals in that game, and in the third period with 2 minutes to go, the big guy that it was getting schooled all game came and checked him into the boards, and now this kid's concussed and he's out for 2 months because the other kid took a cheap shot on him. That's a preventable injury. I understand there's going to be injuries in hockey, there's going to be injuries in basketball and soccer, but these are preventable injuries, and we're not penalizing the aggressive player. Maybe he gets a 2-minute penalty, but then he's back the next game. The other child's out for a month. So, so I think that we can really cut down on that with officiating, parents, culture changes there. Promoting fair play, promoting respect is very important. Rule change examples. In 2011, USA Hockey, their Player Development Committee, recommended that a proposal be submitted that delays full body checking until the 14 and under youth classification. Studies were done in Canada that showed that we reduced concussion rates by delaying until they're a little bit older, have a little bit more coordination. Let them work on skills when they're young, and save that body checking. Teach them how to body check. It's very important, but they're not able to anticipate a hit in hockey and get up to where they can protect themselves, since that's a big problem. 2012, Pop Warner Football instituted rules. It says no full speed head-on blocking or tackling drills in which the players are more than 3 yards apart. So that drill that I showed you at the very beginning, they were more than 3 yards apart. That would be banned now, and should be no intentional head-to-head contact, in Pop Warner at least. The amount of contact, limiting the amount of contact in each practice to reduce to a maximum of a third of their practice time. This is just coming out. November, there was a lawsuit that was settled, United States Soccer Federation, and so it's effective January of this year. USSF and US Soccer is saying that they're going to do a lot of changes, but this is again for kids who are playing leagues and clubs that are under the US Soccer governance. So other leagues may not be following this, but improve concussion awareness and education, instill uniform concussion management and return to play protocols. Sounds sort of familiar, right? That's what we're trying to do with our state law. Modify rules to allow players who may have suffered a concussion during games to be evaluated without penalty. That's a problem in soccer more so than other sports because the play doesn't stop. Prohibiting heading the ball for children 10 and under, and limiting the activity and practice only for those ages 11 to 13. So meaning teach them how to head the ball, but until they have the ability to do something with it, have the neck strength, have the body control, and maybe they shouldn't be doing it when they're 7 years old out there practicing and heading the ball a lot. And just like with Natasha, I see it all the time that, kids, especially the girls, no offense, but they close their eyes. And so if one girl closes her eye and the other girl closes her eyes, they both go to head the ball. That's what happened. You saw that girl head her in the back of her head. She was nowhere near the ball, right? That's a terribly ineffective play. So as a coach, you're like, what are you doing? But now Natasha's injured. That other girl kept going and kept playing. So again, preventable injury. Equipment. I talked about the cars. This is a new, this just came out. Visus is a new helmet company up in Seattle, again, University of Washington up there. Some of their neurosurgeons and some other engineers are producing this. So you can see sort of on the left is the sort of collapsible type helmet. So maybe the helmet can conform and collapse a little bit and absorb some of the energy rather than it being transferred into the brain. So equipment changes, I think, are important. So this is sort of just a, let's see if I can get this to play here. Oops. Sort of a brief sort of closing here.
The athleticism will come and go, but what's more important is the child that they are, the kid that they are, and not the athlete that they were.
And just keep being positive, and life is definitely worth living. You know, just make the best of it. That's what I would say.
So that's a website that Texas State Athletic Trainers Association and UT Southwestern and some of us are trying to work on, and we need some content, we need some good material. So any of you guys that are involved in concussions or doing things at the research level or at the clinical level, reach out to us. We'd appreciate some help. So this is sort of just summarizing current guidelines, pulling them out immediately. They don't go back the same day. We're not grading concussions. Physical and cognitive rest. They can't go back till they're symptom-free, and then when they are ready to go back, they need to complete a gradual return to play protocol. That's sort of the concepts that everybody is agreeing upon at this point. So I appreciate your time, and we may have a few minutes for questions or discussion.
So, Dr. Miller, I really enjoyed the talk, and I really just have two questions. The first would be, if when an athlete is considered recovered from a concussion, are they at greater risk for future concussion? And if so, how greater? And my second question would be, is there a point at which an athlete, depending on the severity of the concussion or the repeated nature of concussions, where they should consider just foregoing that athletic endeavor altogether?
Yeah, I appreciate it. So two great questions. First question on return to play and increased risk. So the risk of a subsequent concussion is increased by 6 to 8-fold following the first injury, but that risk is usually most significant the first 2 to 3 weeks after the injury. And if we remember going back to that chart, it's saying that a lot of them are not fully recovered in that 2 to 3 week window. So once they are fully recovered, actually, and they're back, then that risk is elevated slightly, but it's not as significant as the first 2 to 3 week window. So that's why a lot of these policies, the athletes end up missing 2 to 3 weeks. And so when they do have an increased risk, whether that's because they were at higher risk before, whether that's because their brain now has sustained damage that puts them at risk, or whether it's because they're an athlete who's going to go back to doing the same thing, whether that's tackling with their head down or playing soccer or whatever it is that caused their injury in the first place, or perhaps a combination of those, I think we don't know yet. So there is a slight increased risk. In terms of retirement from contact sports, that's a discussion that I have more frequently than I like to have. And I really don't like having it with a 11-year-old who's had 4 concussions. Or, it's never fun when it's an 18-year-old who has a college scholarship already, right? And they have their plan and they want to go, and that's how they're paying for their way through college. But I'm seeing it more and more frequently in the younger kids. So that's where I think that we can prevent. These kids are never even having the opportunity to play in middle school these sports because they're continuing to go out and get injured and injured again. So there's not an absolute or magic number. We used to sort of say 3. And so, if they've had more than 1, then I start at least introducing the concept is that, at some point we may have to start to think about other sports with lower risk. But if they have 1 concussion and they take 6 to 9 months to recover, they've missed a whole semester or a school year, perhaps that child shouldn't sustain another concussion because they're going to miss another school year and they're going to be really behind. So maybe now is a good time. I think in general, when it comes to sports medicine, if we're disqualifying an athlete from one sport, we always try to find an alternative sport that they can participate in. It's not that you can no longer play sports. It's instead of football, let's look at maybe running cross country, or let's look at swimming. Let's look at something different. So I have a list of sports that shows contact, limited contact, and non-contact to allow them to sort of choose. And I've had a lot of former athletes that have retired who have gone on and won state championships in their new sport. So I tell them, you're an athlete. You are not a soccer player or a basketball player. I understand that that's what you focused on for a lot of your life, but you are an athlete, and you're really good, and you have these skills you developed, and let's just find something else that you enjoy, you're good at, and transition you over. But absolutely, I think that we're seeing that more and more. And part of the problem is because we can't predict down the road who is going to have problems. There's one of the neurosurgeons at UT Southwestern who played football at Stanford, and he said, I've had 5 concussions, and he's brilliant and a great neurosurgeon, and he's obviously doing fine. But yet there are some people who, Owen Thomas, who've never had a concussion, who struggle. So I think, as we are able to predict and know more, that will help guide us in terms of some of these retirement decisions.
I think you mentioned the cultural issue, which I think is really interesting.
I think you mentioned the cultural issue, which is really interesting because what makes an athlete and a superb athlete is their desire to stay in the game, and that's our biggest enemy. So my first question is, what do you think the medical community can do with regards to that culture? And my second question is, I used to be a soccer referee for a long time, and I was wondering, is there any effort to inform soccer referees about, obviously they can't diagnose anything, but maybe some of the basic signs of a concussion, because they have control of when to start and stop the game.
Mm-hmm.
So
It's a good question, and I think that I wish that I knew how to get athletes and coaches to listen to us more. I think that the athletes like Natasha are a good way in. When I go and give talks like this to head football coaches that are required now because of the law, I start off with a video from ESPN. ESPN does great videos, and they have one on second impact syndrome and a former collegiate football player, Preston Plavridis. And I think that hits home more when they see somebody that's in their shoes. They're like, all right, that guy was a pretty legit football player, and now he's brain damaged. Maybe this is something I need to pay attention to, versus me standing up there in a tie and saying you should listen to us as doctors. And so I think that using athletes, former professional athletes, and people that are sort of been in the game, former coaches coming back. Mike Singletary has done a lot of work with us up in Dallas. He's been living up there and going out, and he and I have been giving talks together. I mean, he's a fascinating motivational speaker, but people are going to listen to Mike Singletary because he's been there. He's been at the highest level. He's coached at the highest level. He's won the Super Bowls. And so I think that really is important, not just the medical community. We need to continue to find the answers, but we need to engage the athletic community to help us educate and get buy-in. As far as soccer coaches, I think same thing. I go out and give talks to the community soccer leagues and coaches and parents and officials, trying to educate them. And when I tell families, every time I treat a family, I tell them, go tell all your friends and families in the soccer team, tell your coaches, because that's how knowledge spreads, right? It's not us one at a time doing it. It's dissemination of knowledge amongst everybody and trying to educate the masses and the public to help us to get out there.
One more question over here.
I understand the law pretty much UIL schools and all of that. What about with, the YMCA associations with the football and soccer and everything else? Is there any future direction that the law will expand to include them, that they are required to have physicians and stuff? Because right now they don't, and it's parents that coach.
Right. So the question in terms of non-UIL youth leagues and clubs, and you're right, it's very difficult. And I think a lot of it is funding. Is that we have to be cautious not to implement legislation that will make these leagues not be able to function if we don't have the ability to provide the resources for them to do so. It's a similar concept as EKG screening for every athlete for sudden death. Is if we mandate that every athlete has an EKG, maybe some kids are not going to be able to play because they can't afford it or they get screened out. And so until we have the ability to do that in a good system. So I think that they were cautious when they rolled out the first law to say, we can legislate public schools, UIL, through the Texas Education Agency, and we can sort of make these changes and see how it goes. So definitely, I do think that there's going to be changes in the future, but it's going to take all of us being involved and understanding how we can roll those out, and we have to make sure that it's going to be effective. I think that's part right now is trying to learn is this effective legislation, and if not, then how can we make things better before we do mandate it?
Well, I think that is something that you start with people
a lot of kids have had a concussion before they ever get to middle school or high school. That's right.
There are a lot of good resources on the website that Dr. Miller has mentioned, and also some on the American Academy of Pediatrics website regarding just the things that have been talked about today. So each of you as a health professional, athletic trainer, physical therapist, nurse, school nurse, physician, all have an opportunity here to educate parents about the risk associated with this. Thank you, Dr. Miller, for a very enlightening talk. The reason he's so good at this is it's not just theory. He's a team physician for two different schools and for an NFL hockey league. So he sees it and does it, and I'm sure he'll be happy to talk with any of you who want to come up after our meeting today and talk to him a minute. There's a flyer on the table I'd like to encourage you to take and come back on February 16th. That's next Tuesday. John Dean, who is affiliated with the Advisory Board Consulting Group, will be here to talk about delivering health care in a consumer world, or the state of the union of health care. John was formerly located in Galveston many years ago and has gone on to have quite a wealth of knowledge in health care and the economy. So join us for that, if you will. It'll be in the Clinical Science Auditorium.